Hello, my name is Wendy Lomers, and we at Acclaim would like to thank you for taking the time to review this presentation. We hope that you will leave with a better understanding of the new payment system that Medicare is developing and the quality metrics that will be affecting the payments you receive for taking care of the Medicare population. While we're not certain, we anticipate that these quality metrics will also affect the payments that you receive from other payers in the future. This presentation will focus on how MIPS will apply to the specialty of radiology and is based on the final rule with comment period issued in October of 2016. As you know, Acclaim is here to help you with all things radiology. What you will learn is that many of the MIPS requirements can only be accomplished through the efforts of the physician or the group. Acclaim hopes this presentation will help you, our physicians, understand the new MIPS, and we will continue to guide you to the right resources as you face this new challenge. MACRA, the Medicare Access and CHIP Reauthorization Act, was passed in April of 2015 to replace the sustainable growth rate system that we all recall created a looming 20 to 25% cut that threatened physicians each year. Congress continued to delay the cuts, knowing that physicians would not be able to afford to continue providing care to Medicare recipients in light of such drastic cuts. They were seeking an alternative system to replace the SGR, and finally, in April of 2015, they passed the act known as MACRA. MACRA set up a system of very small increases to the Medicare physician fee schedule that covers the time frame within which the details of the new payment system will be worked out. It also set up a framework for a new payment system called MIPS. May 9th Federal Register included the proposed rules for MACRA, and many interested parties made comments on the proposal. The final rules with comment were released on October 14, 2016, with the first performance period starting on January 1, 2017. In order to be prepared, physicians need to start right now identifying the various components and selecting the participation level for your individual or group. You will be better prepared after you complete this review of MIPS. MIPS stands for Merit-Based Incentive Payment System. In addition to replacing the SGR, MIPS brings together many of the other programs that Medicare had in the works. As you can see, it combines PQRS, the Electronic Health Records Program, and the value-based modifier. The program also includes measures that attempt to gauge how efficiently physicians perform their work and use the healthcare resources. MACRA set up two paths. Physicians will either participate in the new MIPS, or they will be a major participant in an advanced alternative payment model. Medicare is encouraging physicians to participate in programs that move the payment system away from fee-for-service and into alternative payment models. They would like to see the payment system change to encourage communication between the various caregivers, hoping that this communication will result in the most efficient path towards the best outcome for the patient. I will distinguish the difference between any alternative payment model and those called Advanced Alternative Payment Models, known as AAPMs. The AAPMs include a component of downside risk, which means that the money can be taken away from the physicians if the results do not improve and costs increase. The government is spending a lot of money on researching how to measure quality and value, resource use, outcomes, and the like. They believe that shared financial risk will motivate physicians to do a better job of coordinating care. This is a huge project, and I believe that there will be much experimentation with alternative payment models until one or more are found to be successful and acceptable to the healthcare providers. We are facing changes in the healthcare payment mechanisms, and it is hard to predict where they will end up. MACRA provides funding for research and gives MIPS credit to providers for participating in alternative payment models. This alternative payment model participation will vary depending upon the integration levels of the local healthcare economy. For example, it will be easier for Geisinger to participate in an APM because most of the providers associated with them have access to a shared electronic health record. On the other end of the spectrum, it will be more difficult for a geographic region that has disparate systems that don't communicate. The key to these models is to have an efficient way to coordinate the care of the patients involved, a shared computer system. The first risk sharing started decades ago with capitation for the primary care physicians. The APMs of today will go much farther by including all the care providers in one bundle payment, sharing risk across all specialties. A challenge for sure. If you follow this logic, you can probably figure out how your specific geographic region will initiate the first APM. Knowing that all physicians are incentivized to participate in APMs, it will be important for radiologists to stay attuned to the local healthcare systems and the physicians that refer them patients so that the radiologists are included in these APMs as they come to fruition. They will likely be discussed in the physician's lunch area, at local medical society meetings, or even at a medical staff meeting at the hospital. The hospital is also incentivized to participate in APMs, so they may be the first to coordinate this effort in some communities. One of the most likely entry points to an APM could be through a Medicare Shared Savings Program. This program requires an integrated healthcare system such as an ACO to accept responsibility for the care of a group of Medicare patients. This ACO has the opportunity to share in certain savings that occur when the patient's care is handled in an efficient manner. Radiologists should ask those involved in their local healthcare market if there is any chance to participate in one of these Medicare Shared Savings Programs. Since all providers involved in a Medicare Shared Savings Program share in the cost and quality metrics achieved, it will be important to have confidence in the ACO's ability to properly manage the processes and outcomes. As I mentioned, there is an important distinction between any APM and an advanced APM. The advanced APM subjects the physician to downside risk. In other words, the physician can have money taken away if the cost or outcomes of the patient are not improved. While there is MIPS credit given for participation in APMs, the new rule requires that a significant portion of a physician's revenue be derived from the participation in an advanced APM in order for the physician to avoid participation in MIPS. MIPS is properly described as a combination of many of the pre-MIPS quality systems. The new final rule sets out a transition or developmental period for the first few years. This system will morph over time as all of the stakeholders provide input to CMS regarding how it works for their various specialties. That is why understanding it from the very beginning will prove beneficial in the long run, like learning the alphabet before you learn to read. It just makes it easier. So now let's review the pre-MIPS systems and what they will look like in MIPS. Each of the pre-MIPS systems have certain aspects included in the four components of MIPS. PQRS and value-based modifier is replaced with the quality metrics component. The electronic health record system is replaced with the advancing care information, and resource use remains similar in the new system. The clinical practice improvement activity component is new under MIPS. This component of MIPS is new and does not mimic any of the past CMS programs. I mentioned the alternative payment models before. The CPIA scoring gives credit to providers for participating in alternative payment models. CPIA requires physicians to implement improvement activities that CMS anticipates will result in improved patient outcomes. More about CPIA in a bit. Now that we have reviewed the CMS programs in place and how they morph into MIPS, let's review why physicians will want to participate in the new MIPS program. First, realize that Medicare will be adjusting the payments to all physicians based on how well they participate in MIPS. There will be bonuses paid to those who have higher value scores and penalties paid to those who have lower value scores. The total Medicare physician fee schedule payments remain the same, and the money taken from some will be redistributed to others starting in 2019. There is also money set aside for those who participate in advanced alternative payment models. Participation in AAPMs, even when they do not meet the minimum threshold needed to avoid MIPS, minimizes the efforts needed to meet MIPS requirements. For those who do meet the minimum threshold, the Medicare money paid each year will be increased by 5%. Now you can better understand why I say that all providers are motivated to get involved in APMs. There is the potential for a 3 times multiplier applied to the incentives paid to those whose performance is above the benchmarks. In a budget-neutral fashion, it is determined by how many physicians are below and above the benchmark. If many below the benchmark with fewer above the benchmark, it will allow those few above the benchmarks to have a higher multiplier. Still not convinced you want to be at the top of the quality value food chain? The government also set aside $500 million a year to share among those physicians who participate in all quality metrics. Early adopters will be more likely to gain a higher share of these funds. For the initial year, 2017, CMS has set the benchmark for receiving this additional money at 70 points. We will discuss how this works in a bit. There is a Physician Compare website that is available to anyone who wants to access it. You will want to know what yours says. While patients may not access your quality metrics because they rarely choose their radiologist, except maybe interventional radiologists and breast imagers, you can be sure that the hospitals will want to view their radiologist data. I can also imagine that attorneys may access this information. That is why it is important that you become familiar with this system and accept personal responsibility for your quality metrics. We have reviewed the pre-MIPS systems and what is at stake. Now we will look at the metric-based incentive payment system called MIPS. The MIPS scoring system is made up of 4 components, and the performance scores for each of these come together to form the MIPS Composite Performance Score. MIPS will result in all physicians being scored a number between 0 to 100. I want to be sure to give credit to CMS for providing ongoing education on the new MIPS program, which helps all providers understand the payment system. Here's a link that will provide as an additional resource. This presentation will focus on MIPS as it applies to those working in imaging. This shows how pre-MIPS systems compare to the MIPS components. MIPS brings part of the prior systems into play. You can see that the quality mimics the PQRS. Advancing care information brings in many of the EHR program requirements. One major difference between EHR and ACI is that ACI is not an all or nothing system. Resource use is still compiled from claims data, but they have added a few more metrics. And the new piece is the clinical practice improvement activities. We will delve into these further in a minute, but I wanted you to see how the components of the prior system are morphing into MIPS. The new macro provided for 2 pathways, MIPS, which for the 2017 performance period will include a very large percentage of the physicians, and Advanced Alternative Payment Models called AAPMs, which is the path that will be taken by those physicians who participate in risk-sharing payment systems. For 2017, most of the AAPM participants work in integrated healthcare systems, but other AAPMs are being developed, and through research efforts, more of these types of payment models will be added in the future. The final rule indicates a separation between MIPS scoring for physicians who are involved in alternative payment models, even if the alternative payment model does not include the downside risk required to qualify as an advanced alternative payment model. These physicians remain in MIPS and must comply with the reporting requirements, but there is a separate scoring that provides credit for their APM participation under certain categories of MIPS. The end goal is to push the Medicare payment system away from fee-for-service and end up in a more integrated system that rewards value. Right now, value is based on quality and resource use, but CMS indicates that the ultimate measure is improved outcomes for the patient. While no one can predict exactly where this metric-based incentive payment system will end up, it is important that physicians understand as much as possible. Quality metrics are already being monitored. Medicare has established websites that compare the quality metrics associated with each physician and each hospital who provide health care to Medicare recipients. ICD-10 was implemented so that more specificity could be provided, which is expected to help the research being performed. The detailed claims data that Medicare has is being shared with qualified entities who will work with others to analyze the data, looking to establish unique situations that might improve the cost and/or quality of care. There are also other changes anticipated for the sole purpose of gaining a better understanding of the care being provided. I mention these to make you aware of the efforts that are underway. We will now focus on the MIPS side of the new payment system, since this will apply to most physicians for 2017. Who will be participating in MIPS? We will delve into the performance categories and how they will be scored. We will look at how this information will be reported to Medicare, and we will look at the performance periods and when the payment adjustments will be implemented. Lastly, we will look at the options available for 2017 reporting period, since the final rule has lightened the burden for this inaugural year. For year 1 and 2, you can see a list of who will be eligible. The Secretary has the ability to change the participants over time. As you can see, radiologists fall within the eligible clinician group. So who will not be required to participate? MIPS only applies to Part B recipients, so that only the physician side, not the facility side, are eligible for MIPS. Brand new Medicare providers in their first year of enrollment, not their first year with the group, but the first year of enrollment in Medicare, will not be eligible to participate. And low-volume Medicare providers who bill very little to the Medicare system. Also, as I mentioned, those providers who are active at a substantial level in an advanced alternative payment model do not fall into MIPS. Participation can be individual, or the group can choose to combine all the physician scores within the same tax identification number and share those scores with all group physicians. This is similar to the prior G-Pro in that you must make the election every year by June the 30th for the current year, and the election is irrevocable after June the 30th. Again, here are the performance categories that are combined to determine the composite performance score for the physician or the group. I come back to this because we are going to be exploring each of these 4 components and want to make sure that you start with the basics. The scoring for each component will be combined into the MIPS composite performance score for the physician or group, if reporting as a group. Each physician or group practice will receive a MIPS composite performance score between 0 and 100. Here is a summary that was shown in the final rule. It shows how each of the 4 performance categories are measured and how the proposed rule compares to the final rule. For those who never reviewed the proposed rule, the last column is the most relevant. Each of the categories is scored separately and then combined to come up with the MIPS composite score. Quality and resource use data are both compared to their respective benchmarks, which are determined using accumulated data from all participants. This comparison determines the points that the physician or group will be eligible for in each of these areas. Reporting additional measures can also produce bonus points. The clinical practice improvement activities are reported, and the scores are determined based on the number of points that the physician or group earn as compared to the maximum available points. The advancing care information has 2 levels of participation, a base score and a performance score, which is based on how many participation levels the physician or group can accomplish. There are also a few opportunities for bonus points in the advancing care information category. The score for each category is weighted when it is accumulated into the MIPS composite score. The first year shows as 2019 because that is the year that the payment adjustment will be applied to the payments, but 2017 is the performance period for the 2019 payment adjustments. This means that the first performance period begins January the 1st, 2017. As you can see, the first year shows that the quality performance category will be weighted at 60%. This is good news since many radiologists have been reporting PQRS, and the reporting for the quality component is very similar to PQRS. This scoring changes over time, as you can see. This is the weighting that has been assigned for year 1, which is the 2017 performance period. As you can see, the quality metrics have the heaviest weighting, and the resource use has the least weight. Again, this is the weighting that has been assigned for year 1, which is the 2017 performance period. As you can see, the quality metrics have the heaviest weighting, and the resource use or cost category has the least weight. Since most radiologists have not been assigned the various cost components, this will give CMS and the radiology community more time to establish specialty-specific cost measures for the future. The Quality Resource Use Report for radiology groups have shown only one cost metric, which was Medicare spending per beneficiary, and even its relevance to radiology is questionable. It was not a good measure of the radiology community's resource use, so this zero weighting is a good news for 2017. We will start with the quality performance category, since it is a category that most radiologists will be familiar with. The 2017 quality measures align with the PQRS measures that the radiologists have been reporting for 2016. The reporting requirement proposed a drop from 9 to 6 measures, and instead of a quality domain requirement, there is now a measure type requirement. The measure type includes a label called Outcomes Measurement, and more emphasis is given to reporting outcome measurements. In some cases, the physician or group can select to report on a specialty measure set, which, if successfully reported, would meet the 6 quality measure requirement even if the set included less than 6 measures. There is also one population measure that is measured by CMS using claims data, but it is not yet clear if this would be applicable to radiology. Since radiologists became accustomed to reporting the PQRS measures and the new quality measures are similar, it is fortunate that the quality performance category makes up 60% of the composite performance score under MIPS for year 1. Again, the quality measures are proposed to be almost exactly the same for 2017 as they were for 2016, with a few caveats. There are still quality domains assigned to each measure, but the measure type is more meaningful in 2017 because there are requirements that include reporting on specific measure types. For example, there is a requirement to report on an outcome measure. The measures have also been assigned a priority level. Note the measure type on the sample here shows that these are process measures. The measure types also include outcomes measures, appropriate use, patient safety, efficiency, and other. The first column also provides valuable information. An exclamation point indicates a high priority measure, and a double exclamation point indicates the measure is a high priority measure that is also an appropriate use measure. This information is important when you're selecting your measures. There is a definition in the final rule for non-patient-facing eligible clinicians. The contention is that these physicians have few, if any, encounters with the patient, and this potentially limits their ability to meet all of the MIPS reporting requirements. So some concessions have been proposed. Note that most radiologists will fall within the final rule definition of a non-patient-facing physician, since they will not bill encounters for more than 100 times in a given year. CMS decided that the physician would benefit from knowing in advance if they qualify as a non-patient-facing physician, so the final rule has a 1-year look-back period that runs from September the 1st, 2015 to August 31st, 2016 for the 2017 reporting period. This is known as the non-patient-facing determination period. These non-patient-facing clinicians are allowed to report on a specialty-specific measure set, as mentioned before. The final rule allows CMS to reset the weighting between performance categories for certain physicians if they are not able to find sufficient measures or activities to report on. Again, whether reporting as an individual physician or as a group, 6 measures will be required, and they must include a cross-cutting measure and an outcome measure. If no outcome measure is available for your specialty, then it can be replaced by a high priority measure. There are outcome measures available to radiology, and the proposed rule regarding non-patient facing physicians may end up eliminating the need for cross-cutting measures for radiologists. If an individual cannot find 6 measures, they should report on all available measures and the scoring will be reweighted. These requirements establish how you will select which measures from the available measures. Again, whether reporting as an individual physician or as a group, 6 measures will be required, and they must include an outcomes measure. If no outcomes measure is available for your specialty, then it can be replaced by a high priority measure. There are outcome measures available to radiology. There are also 2 sets of specialty measures. If an individual cannot find 6 measures, then they should report on all the available measures and the scoring will be reweighted. This is similar to the measure applicability validation test that was applied in PQRS. There are bonus points available for the quality measure component, as you can see here. The bonus points earned cannot exceed 10% of the total points achieved under this category. We will look at a sample of the quality scoring in a second, but let's talk about it conceptually first. Quality scores for each measure are converted to points using a decile system. Medicare will use the reported data to determine where the combined performance score of all physicians fall within the decile system. If a physician or group's performance falls within a decile, then partial points will be awarded. For 2017, if a measure is successfully reported at all, it will receive a minimum of 3 points. This caveat is part of the 2017 concessions to make it easier for physicians to avoid the penalty. The concept is that all the scores earned by all physicians will be distributed across the 10 decile points, and then the individual physician's quality score will be compared to the distribution, and that will determine what points are given for that particular quality measure. Each quality measure is worth 10 points, maximum. Again, the points associated with any single quality metric is determined using this decile system, with a maximum of 10 points available for any single measure. If 6 measures were not reported, then for every measure that was available but unreported, the score will be 0. So let's look at a sample showing the actual distribution of the combined performance scores at the bottom of the decile blocks, showing how all participants' scores fall within the deciles. As you can see, the top decile had performance scores from 86 to 100%. Anyone with a performance at or above 86% will receive 10 points for this measure. A participant with a score of 19% will receive about 3.3 points. One component of the final rule includes scoring for topped-out measures, which work exactly the opposite of the college concept of scoring on a curve. It is likely that the most common and easiest measures will result in high performance for most physicians. These will be considered topped-out measures and will result in lower scores because of their simplicity. These measures could result in lowering the physician's overall scores when you anticipated having 100% performance. The first year that a measure meets the topped-out requirement, it will not be scored as a topped-out requirement, meaning that it will not hurt you in that year. Let's look at an example of a topped-out measure. As you can see, half of the eligible physicians or groups ended up with a performance score of 100% on this particular measure, indicating that it was an easy measure. Since the middle of the cluster is at 8.5, that will be the score that all of the physicians will receive for this topped-out measure if they had a performance score of 100. For each year after 2017, CMS will develop a list of topped-out measures based on the prior year's results. They'll make this list available prior to the start of the performance period. Therefore, physicians will know ahead of time which measures will be considered topped out and may want to avoid these measures because even with a perfect performance, they could result in less than 10 points for that measure. Here's a sample of the quality scoring for one physician, Dr. Jones. Note that the last 3 measures, acute composite, chronic composite, and all-cause hospital readmission measures, are shown as administrative claims measures. These administrative claims measures do not require any special reporting and are calculated by CMS using the physician's claim data. There are specific requirements for CMS to use these that require a significant sample size, meaning that it is based on a large enough number of claims and other specific requirements. Fortunately, at this time, there are a few of these administrative claims that pertain to radiology. So back to the scoring. The middle column shows the performance scores for each of the quality measures reported by Dr. Jones. See Measure 1, 2, and 3 with scores of 4.1, 9.3, and 10 respectively. Then in the last column, you can see that these three measures were reported through an electronic health record, which provides a bonus point of 1 for each of these measures. I have not encountered a radiologist who has ever been able to report their measures through an electronic health record, so it is unlikely that these bonus points will be available to most radiologists. For Measure 5, the high priority measure, it added a bonus point in column 6. Dr. Jones did not report 6 total measures. This resulted in a 0 for that measure. The 5th column indicates the total points available for each measure. When you total them up, you come up with 48.2 points out of a possible 70 points. But then you add the 4 bonus points, which brings it up to 52.2 points out of a total possible 70 points. This results in a 74.6% quality performance score. So let's see how we came up with that 74.6%. Here's another depiction of the same calculation. Dr. Jones gets 52.2 points out of 70 total points, which results in the quality performance category score of 74.6%. Let's review the resource use summary, another MIPS component. There is no special reporting for this component since Medicare uses the administrative claims data to evaluate spending in different areas. The final rule added more than 40 new episodic specific measures to cover additional specialties. Again, the physician or group data is compared to national benchmark to determine performance. There are so many new cost measures that will not have data for benchmarking since it is based on the prior year data, that CMS set the weighting for cost or resource use at 0% for 2017. Hopefully, this inaugural year will allow time to better understand the cost attributed to physicians and physician groups, especially radiology groups. Here are a few of the measures that have been utilized as part of the group's Quality Resource Use Report, known as the QRUR, which was the prior method of gauging resource use. For radiologists, the Medicare spending per beneficiary measure is the only resource or cost measure that has shown up in the past. Until recently, most of the measures have been most relevant for physicians who provide some form of primary or specialty care, not the consultant physicians. But as shown here, there are 40 additional measures that are starting in 2017 in an effort to reach other specialties. These will be benchmarked in 2017 and used thereafter. Clinical practice improvement activities is a new category. It is referred to as CPIA, and the activities required are known as improvement activities. This category gives full credit for physicians who are part of a patient-centered medical home, because the patient-centered medical home already has internal improvement activities in place. There are over 90 improvement activities listed in the final rule, and many appear to be relevant to radiology. Participation in a qualified clinical data registry will provide access to improvement activities. I will show an example of the list of improvement activities in a second. Improvement activities are weighted as medium or high, and a medium activity is worth 10 points, while a high activity is worth 20 points. Let's look at what is required if the physician is not part of a patient-centered medical home. For those physicians who are not a part of a medical-centered home, these are the reporting requirements. There is also partial credit given to physicians or groups that participate in an alternative payment model. Activities are given points as mentioned before. The general physician population will need to report activities that will earn them 40 points, so either 4 medium or 2 high-value activities. Each of these activities must be performed for a period of at least 90 days for 2017. A number of the improvement activities also qualify for bonus points under the Advancing Care Information category. These activities utilize electronic health record systems, so they provide beneficial credit in both the CPIA and the ACI categories. I mentioned non-patient facing clinicians earlier and said that there was special consideration given to these in the final rule. The Secretary is given latitude to make concessions such as revaluing components that are difficult, if not impossible, for non-patient facing clinicians. Here is one of the concessions provided to help them. Again, these are physicians who report less than 100 face-to-face encounters. So for most radiologists, at least those who qualify as non-patient facing physicians, full CPIA points can be achieved by reporting 2 medium activities or 1 high-valued activities. These activities can be found on the Quality Payment Program website listed here. Here is a list of the subcategories that describe the various improvement activities. In addition to subcategories, all improvement activities have been assigned, again, a medium or high value weighting. The selection of activities will be based on these weightings. As promised, here is a sample of a few improvement activities that are available for reporting. Note the weighting to the right. Here's another example. Note the different subcategory and the high weighting. As mentioned before, these improvement activities are available on the Quality Payment Program website that is offered by CMS. Here are a few of the improvement activities that also earn bonus points within the Advancing Care Information category. Again, these bonus points are allowed because CMS believes that the use of an electronic health record will improve patient care coordination. You can see that these are identified in the 4th column by an asterisk. Now we will look at the Advancing Care Information component. This shows how the ACI performance category is scored. There is a base score and a performance score that totals up to a possible 130 points. If a physician or group earns 100 or more points in the ACI category, they will receive the full 25 ACI points available for this component. That would be the 100 ACI points, maximum, times the 25% weighting for the ACI performance category. That is how the physician gets the 25 points that are combined to achieve the overall MIPS performance score. Here are the 6 objectives for the base ACI score, which is a maximum of 50 points. As you can see, this component was derived from the Electronic Health Record Incentive Program of the past. Each of these objectives focus on using technology to interact with the patient and the healthcare system in general. As you can see below each area, there is a short description of how that objective will be reported. Some result in percentages, and others are simply attestations stating that you accomplished the objective. Here are the 6 objectives for the base ACI score, which is worth a maximum of 50 points. As you can see, this component was derived from the Electronic Health Record Incentive Program of the past. Each of these objectives focus on using technology to interact with the patient and the healthcare system in general. As you can see below each area, there's a short description of how that objective will be reported. Some result in percentages, and others are attestations stating that you accomplished the objective. Further, there are 80 points available for additional activities in these areas. Not all activities qualify for these performance points. Together, the 50 base points and the 80 potential performance points offer the opportunity to get 130 points, but remember, only 100 points are needed to achieve the full score for the Advancing Care Information component. One large difference between the Electronic Health Record Incentive Program and the Advancing Care Information is that the new ACI provides the opportunity to earn percentage points in many areas. That is better than the prior all or nothing reporting used by the old EHR incentive system, where you had to fully meet all objectives or you failed to get any points. Here is a sample of the type of measures required under each objective. The first one is an absolute requirement. You must say yes to having a secure system that has been analyzed for risk. The others are reported as either a percentage with a numerator and a denominator, or it is an attestation of fact with a yes, no, or null answer. The measures that have a yes in the far right column are eligible for earning points in the performance score portion of the ACI. Each may earn up to 10 or 20 points as specified by CMS. There is also the ability to earn a bonus of 5 percentage points for reporting additional measures. Lastly, as mentioned before, a physician can earn a bonus of 10% points for attesting to completing one of the improvement activities that specifies the use of an electronic health record system. All that said, the final rule allows CMS to reweight the categories for specific specialties if the physicians are unable to meet sufficient measures within a category. This could result in the category having a lower weight in the MIPS composite performance score, since the hospital-based physicians do not have the ability to modify or control the electronic health record. When the MIPS performance weighting is reduced for ACI, it means that the other categories will have a greater impact on the MIPS composite performance score. Again, this component focuses on how the physicians use the IT systems to meet certain clinical objectives. It allows for partial credit. It has included some specialty-specific objectives. In addition, Medicare has made a special effort to eliminate similar measures that were redundant in the old systems because they appeared in several systems such as EHR and PQRS. For some reason, Medicare eliminated the objectives that might have been met by the requirement to use a clinical decision support system or a computerized physician order entry system, which would have been relevant to radiology. This component is weighted at 25% for 2017. The MIPS Final Rule included a definition for hospital-based clinicians. It includes those whose services are furnished in the hospital inpatient, outpatient, or ER setting at least 75% of the time. This is based on the year prior to the current performance period so that the physicians will know if they will be considered hospital-based during the current performance period. This is another of the concessions that CMS made to help hospital-based physicians who might not be able to meet the ACI requirements. Again, any reduction in the weight of one performance category will result in an increase in the weight assigned to other categories. But if you can't make a category, it is best not to be held accountable for it. And this will help with that. Now let's look at the performance periods. 2017 is the initial performance period for MIPS, with the payment adjustments for 2017 performance being applied to the 2019 Medicare payments. This two-year cycle repeats itself going forward. While the 2019 incentives and payments will be based on the performance during the 2017 calendar year, the final rule modified the performance period to allow for scoring of any consecutive 90-day period of time within the 2017 calendar year for quality, CPIA, and ACI measures. Since the resource category has a weighting of 0, this means that the 90-day performance period applies to all measures for 2017. This is a summary of the 4 components of MIPS that includes the point system, the weighting, and a brief description on how the scoring is applied. It makes a really great reference tool. So each component has various ways to submit the MIPS data to Medicare. Here are the ways that quality data can be sent. For radiology, the most common way to submit data is through a registry. This can be accomplished through a qualified registry or a qualified clinical data registry. Physicians who see patients often have EHRs that record data such as the last flu vaccine. This data can then be submitted directly from the EHR to Medicare. As mentioned before, there are also some measures that are calculated based on claims data, called administrative claims. The submission of data for the quality performance category is accomplished in much the same way as the PQRS reporting was. For 2017, participants reporting using the claims method will need to report on quality measures for over 50% of their Medicare patients that are eligible for each quality measure. For all other submission methods, the participants must report on over 50% of their patients regardless of payer that are eligible for each quality measure. Resource use data is always accumulated by Medicare using claims data. No specific reporting is required other than filing claims as usual. Advancing care information requires a combination of reporting mechanisms. Some will require the physician or group to report what % of their patients achieved an objective, and others simply require the physician attest to accomplishing or completing a specific requirement. Clinical practice improvement activities are also reported using a combination or various reporting mechanisms. The most common is attesting to completing a number of improvement activities from the list of available activities. MIPS is a payment system, so let's review how it affects the physician or group's payments. Remember that the MIPS threshold in normal years will be determined by the overall performance of all physicians participating in MIPS. If the individual physician or group's composite performance score is at or above the MIPS threshold, then there is the potential that the physician or the group's Medicare Part B payments 2 years later will be adjusted upward from between 0 and the maximum incentive for that year. On the incentive side, there is also an additional $500 million per year that will be distributed to the top performers. If the CPS is below the MIPS threshold, then there will be a negative payment adjustment between 0 and the maximum penalty for that year, applied to the physician or the group's Medicare Part B payments 2 years after the performance period. So 2019 payments will be adjusted as a result of the 2017 performance. As mentioned before, if a physician's performance scores are higher, then there is a possibility of a 3 times multiplier that could be applied to the available incentives. This multiplier is based on how many physicians are above the MIPS threshold and how many are below the threshold. This is why the 2017 maximum incentive shows up as 12% instead of 4%. Since MIPS is a budget-neutral system, the high performers will benefit at the expense of the low performers. For 2017, CMS has modified the normal assessment of penalties to allow physicians a better chance of avoiding the penalty as they gear up for MIPS. CMS set the MIPS threshold at 3 points, which means that any physician or group that reports a quality measure will avoid the penalty, since a minimum 3 points is achieved for reporting a single 2017 quality measure. So CMS lowered the bar for the first year to help physicians avoid the penalty. This shows the maximum positive and negative payment adjustments for each of the years shown. Again, I mentioned that there is language that allows the upside adjustment to be 3 times the downside adjustment as long as the system stays budget neutral. This will depend on how many physicians and groups begin to participate and how well they perform. The potential for the 3 times multiplier is also affected by the 2017 MIPS threshold being set at 3 points. Here is the normal distribution of how the payment adjustments will be applied based on where the physician's or group's performance falls as compared to the MIPS performance threshold. It also shows that the top 25th percentile will be eligible to share in the additional $500 million available each year, and the lowest 25th percentile will receive the maximum negative payment adjustment each year. I indicate that this is the normal distribution. For 2017, the MIPS threshold has been set at 3 points, and the additional $500 million will be available to those physicians who have a MIPS composite performance score of 70 or greater. This is a transitional concession. Now that we have reviewed the overall MIPS, let's focus on the 2017 reporting options. As mentioned, 2017 is the inaugural year of MIPS, and CMS has provided concessions to help physicians gear up for this new payment system. CMS indicates on the Quality Payment Program website that there are 3 reporting options outside of not participating and receiving the maximum penalty. The Submit Something option allows physicians or groups to report on 1 quality measure or 1 improvement activity, which would provide them with a score of 3 points. This would allow them to avoid the penalty. It would also show up on their physician website as having a score of 3 points in a system that scores up to 100 points. The partial year option allows reporting of activity for 90-day performance periods, and this allows the physician or group to avoid the penalty and provides the potential to receive some small portion of the available incentive. Full reporting is considered fully participating in each of the MIPS performance categories for the full year. While the CMS website states that this will provide the opportunity for a moderate positive payment adjustment, this is the path that provides the potential for the highest MIPS composite performance score and the best chance for the maximum MIPS incentive. Also included on this slide is the fact that a physician or group can avoid reporting MIPS at all if for 2017 they have 25% or more of their Medicare payments coming through an advanced alternative payment model, or if they see 20% or more of their patients through an advanced alternative payment model. This alternative will yield a 5% incentive payment in 2019 for this 2017 performance period. The payment system is changing. The first MIPS performance period will begin January 1, 2017, resulting in payment adjustments of the 2019 Medicare Part B payments to physicians and groups. Almost all radiologists will be required to participate in MIPS. Only a small number of brand new radiologists or a small percentage of radiologists who are part of an integrated healthcare delivery system will not be participating. These would need to have 25% or more of their Medicare payments coming through an advanced alternative payment model, or be seeing 20% or more of their payments through one of these advanced alternative payment models. Now is the time to become familiar with each of the 4 components of MIPS. In order to maximize reimbursement, each physician and group is responsible for ensuring they endeavor to have the highest possible performance scores in MIPS. These are the steps that physicians need to be taking right now. Decide if you will be submitting something, partially participating, or fully participating based on the 2017 reporting options. Full participation is the best option for obtaining the incentive, and this year will provide physicians and groups an opportunity to hone their skills and be ready for the future. Experience with groups that are participating in qualified clinical data registries has shown that these registries are actively assisting physicians and groups to meet the various requirements of the new payment system. Also, evaluate whether the group would achieve better performance scores if they reported as a group versus reporting on an individual basis. And remember, this election must be made prior to June 30th of 2017 for the 2017 performance period. I want to mention again that the quality metrics we have discussed have been and will continue to be reflected on a Physician Compare website that is maintained by Medicare. These scores and metrics are available to anyone on the Internet. This shows some of the other metrics that are included. Medicare is seeking quality metrics on all physicians and has stated that they will populate this website with information from many other reliable sources. The QCDR mentioned here is a qualified clinical data registry, such as the ACR's National Radiology Data Registry, which includes a dose index registry and the National Mammo Database, along with other registries. If you would like further information on the Physician Compare website, the CMS offers webinars on this and many other subjects. This Physician Compare website has a parallel website called Hospital Compare, so know that the physicians are not the only ones in healthcare having to meet quality metrics. Hospitals are seeking metrics for all departments, and they should be amenable to assisting the radiologists with quality initiatives as the Medicare payment system transitions from a fee-for-service system to a value-based system. Each physician and group is responsible for watching their quality metrics. Just one more reason why physicians need to have a good understanding of the metric-based incentive payment system. I am sure this all sounds very daunting, like learning a new language. Don't despair. Your efforts to become more familiar with these changes places you ahead of the game. The systems will continue to be developed, and the most important thing that you can do is to gain a full understanding now and stay attuned to the changes. I hope that you feel your time was well spent. The changes in healthcare and their effects on radiology will continue, and hopefully we can journey through them together. Always feel free to call us here at Acclaim if you have any questions or concerns. We are here to help you.